It's a limited release in the United States at the present time. And could you advance the slide for me, please? So what about drug-coated balloons? We had already a very nice discussion yesterday by Jan Baffi about below-the-knee drug-coated balloons, but we have had 3 failed trials of paclitaxel for below-the-knee DCBs. There are several sirolimus DCBs on the horizon. One is Med-Alliance that uses a nanoencapsulation in order to deliver the sirolimus. Another one is seen here. This is a Concept Medical that puts the sirolimus into a phospholipid and then it's absorbed. And keep in mind that Lima's drugs, although they're cytostatic rather than cytotoxic, it's very challenging to have a broad and complete absorption of sirolimus analogs into the arterial wall. They're successful when delivered by stent, at least in the coronary and other applications, but not so easily by direct balloon application. There's also a US-based company, Surmodics, that has done a first-in-human using yet another sirolimus preparation for BTK DCB, and this will be presented this year at the BEAT meeting. Could you advance the slide, please? There are 2 paclitaxel-coated DCBs that are also on the horizon, one from Medtronic that has done a first-in-human study in Europe, and you can see the results there on the left-hand side. Also Aquatech, which is a paclitaxel DCB from China that's had a primary, or let's say a randomized controlled trial with results out to 6 months, with a big difference between DCB and PTA in terms of primary patency. Nevertheless, this will require a larger study, and we'll see if that data holds up. Advance the slide. There we go. So keep in mind that a lot of the BTK DCB data that we have, although it's preliminary, there's also a concurrent effort going on in the coronaries. And I'm not a cardiologist, but I follow this because it's actually quite advanced, especially in comparison to where we are with BTK DCBs. And so what you see on the top of the slide are the paclitaxel preparations. On the bottom are the sirolimus preparations. And these are the studies, randomized controlled trials in the coronaries, the upper ones being for in-stent restenosis, most of which were quite successful. The lower panel shows randomized controlled trials for small vessel disease. And the results are not quite as clear in the coronaries in that sense. But the fact that this parallel effort is going on in the coronaries, I think, is really going to help us ultimately to get a potential to have a BTK DCB. There's also the potential to do focal dissection repair using the TAC endovascular system. This is a device product owned by Philips. And you can see on the left-hand panel the idea that after angioplasty dissection, at least some of the time is inevitable, and the potential then to treat dissections in a very focal manner with leaving the minimum amount of scaffold behind. And this is the subject of a talk I'll give later. The Soval trial has enrolled. This is a paclitaxel-coated self-expanding stent for below the knee. This is a trial that has been enrolled in the U.S. And think of it as a small version of Eluvia. And we'll see what the results are. It's gone on to a phase B enrollment now, which I think will be very interesting. The Esprit bioabsorbable drug-eluting vascular scaffold is enrolling also like BTK, randomized controlled trial, 2-to-1 Esprit versus PTA. This trial is also enrolling, and this of course was based on favorable data from Singapore and Sydney. This is courtesy of Barco. This is published now, showing excellent primary patency up to 4 years. There are also 2 other drug-eluting bioabsorbable vascular scaffolds, R3 Vascular and Riva Medical. It's early for both, but keep in mind that if we know about 2 other startups, there are probably 2 or 3 others that we haven't yet heard about. So I think within a few years, this should be a very crowded field. Below the ankle angioplasty. So, one way to think of below the ankle angioplasty is as an extension of what we already do in the below the knee arteries, but we've never done this before. I have the occasional case from many years back, but think about the entirety of the patient population, the increasing prevalence of pedal artery disease, the fact that we have very limited tools, and then it really starts to look like a true innovation if we can understand and perfect below the ankle angioplasty. I think it could lead to a very bright future. On the other hand, we don't know really what the patency is. There have been no angiographic follow-ups that I'm aware of. It's not an area where it's so easy to understand what the patency is using non-invasive methods. Could you advance the slide? There we go. So there have been 2 studies, one from Turkey, one from Japan. The Rendezvous Registry is probably the largest. And this indicates in patients who had a below the ankle angioplasty added to their BTK angioplasty, that wound healing was faster. However, this is really, even though this is a sizable registry, this is very preliminary, considering that we don't have any patency data that go with it, and that it's not randomized. We also have deep vein arterialization. We'll be talking about this later today, but this is a whole area for development, which is right in front of us. We're right on the threshold of it and the cusp of it at the present time. And then there's also the potential for remote monitoring using wearables and implantables. This is a little bit further ahead, a little bit farther into the future. In the upper left, what you see is essentially a patent application for a stent with a microchip on it. Imagine if you could monitor all your lower extremity interventions by the way the airlines monitor the airline engines. It's all by remote control, so that you know when maintenance needs to be done, or at least when the usual maintenance schedule needs to be interrupted or sped up. This would be an awesome possibility if this were possible. And on the lower panel, what you see is a wearable that'll detect all kinds of heart rates and heart rhythms. And here's just an example of the use of wearables. In this case, to look at the effect of physical frailty on major adverse events after lower extremity revascularization. You know, the truth is our patients come in for 10 minutes, we sit them down, we talk to them, we try to get an impression of what they're actually doing and how they're actually doing. But with a wearable, that would completely change. And then lastly, I would say, my iPhone has 1 billion transistors in it, and yet I'm still doing my procedures using 2-dimensional images and plain fluoroscopy, the same as it was done 40 years ago. Eventually, we will have a GPS like we have when we get on the road in our automobile. We will have that to get to our target lesion. Now, I don't know when that will be. It feels like it's farther away, but gosh, I wouldn't go anywhere complicated in my automobile without my GPS. So, and then lastly, we've heard a lot over the last 2 decades about genomics, and it's taken forever to filter down to the point where it's going to have an impact in vascular disease. But I just wanted to let you know that numerous different aspects of genomics for PAD, coronary artery disease, and large artery stroke, you can see there's a Venn diagram there of various locations on the genome that have a profound effect on that. And then on the lower left, what you see is the cost of sequencing the human genome, which is dropping dramatically. So imagine when your patient comes in addition to getting a CTA, you sequence their genome, and you actually get them on the correct medications for what they have, and think about their natural history with more information. So in conclusion, we're looking at lots of opportunities and advancements in patient assessment, different methods of reconstruction, including excitable things like DBA, wearables, implantables, and genomics. So thank you very much for your time.